Hi everyone. I hope you can hear and you can see me. If I am audible and visible to you, please put a thumbs up in the live chat. I am waiting for to get an indication so that I can start. Okay. So I am so happy to get connected to all of you today, and this is going to be our first class which I am taking for all of you. And I suppose you people who are attending this class are either doing their residency in OBGY, or you are, MS, MD, or you are a DNB student, or you are preparing for NEET super speciality. Now, this class is especially for you all, and if you are a NEET PG aspirant and you are attending this class, then please don't waste your time here. Reason being, in today's class, we are going to discuss in depth about preterm labor. If you are a NEET PG aspirant, you do not need so many details, right? So today's lecture, preterm labor, is going to be covered in around 2.5 to 3 hours. That is what required by these people, by the residents. So if you are NEET PG aspirant, it's not sensible for you to take this class. You'll be wasting your time. Now, welcome all the residents who are attending this class. Now, Bacho, as far as you people are concerned, see, when you are preparing for your exams, whether you are appearing for your MS, MD exam or your DNB theory exam, this is one very important topic, not only from theoretical point of view, but also from practical point of view, because you might get a case on preterm labor. And in that case, you have to know all the details. And that is why I am going to take up this topic in detail. Now, when you are preparing for your residency exams, you need to know so many updates, right? What my target is that during this class, I give you all the important updates which you need to know so that you don't have to run from pillar to post collecting those updates. I am consolidating all the updates for you at one place so that when next you are, whether you are giving a case of presenting a case of preterm labor, or whether you are doing theory examination for preterm labor, you get a question on preterm labor, you have everything at one place, right? The other very important point is, suppose you are a person who's going to appear for NEET super speciality exam. Now, in that case, what the unnecessary details you are going to cut, but then all the updates, you are going to filter all the updates and keep them with you from this lecture over here, right? So let's get going. Okay. Um, oh, so I am bad at seeing your chat at the same time and teaching you at the same time. I will be concentrating on teaching to you. Just in case you have questions, you may put in the live chat, but it is not necessary that I will be looking at the live chat simultaneously. Now, I suppose all of you know, and I'm sure, rather, I don't suppose, I'm sure all of you know what's the meaning of preterm labor and how do you define preterm labor or preterm. See, basically, we are going to talk about preterm birth, right? I am going to teach you about preterm birth. Why we are talking about preterm birth, and uh, more importantly, I'm stressing on preterm birth. That is because not all preterm labors, they end up in preterm birth. So I am going to talk to you more about preterm birth over here. Now, what do you understand by preterm birth? Preterm birth is birth which is occurring from 20 weeks to 36 weeks plus 6 days, right, of gestation. So any female who's giving birth, right, so birth which is happening from 20 weeks to 36 weeks plus 6 days, that is what is preterm birth. Now this preterm birth, there are various definitions for preterm birth, for dividing it into early preterm birth and late preterm birth. So we have WHO criteria and we have CDC or ACOG criteria. Now, as per WHO criteria, moderate to late preterm birth means if preterm birth is happening between 32 weeks to 36 weeks plus 6 days. Right? Very preterm happens if it is between 28 to 32, and extremely preterm is when preterm birth is happening at less than 28 weeks, right? This is WHO's criteria for classifying preterm birth. But on the other hand, there is a CDC and ACOG criteria which we usually follow in our clinics, and that is late preterm birth and early preterm birth. Late preterm birth is from 34 weeks to 36 weeks plus 6 days, right? And early preterm birth is when it is happening at less than 34 weeks. Right? Then you have certain definitions which are based on the birth weight criteria. According to birth weight criteria, low birth weight, what is that? When the weight of the baby or the newborn infant is less than 2.5 kgs. Very low birth weight is when it is less than 1.5 kgs, and extremely low birth weight is when it is less than 1 kg. Right? So this is WHO criteria, the CDC ACOG criteria, and the birth weight criteria, right? In clinics, in your hospitals, in your wards, you are basically following the ACOG criteria because the management protocol which I'm going to tell you is based upon ACOG criteria. Whether we are dealing with preterm birth which is happening in early, that is less than 34 weeks, or whether it is happening at more than 34 weeks. Right? Now, the lower gestational limit for preterm birth is 20 weeks. And suppose if a patient is giving birth at less than 20 weeks, then that is what is called as a miscarriage or an abortion. Right? Now, incidence of preterm birth. The incidence of preterm birth is between 5 to 18%. Roughly, it is around 11%. Right? Now, among all the preterm births which we are experiencing, we see that 80% preterm births are spontaneous and 20% preterm births are iatrogenic. Now, what do you understand by spontaneous and iatrogenic? Iatrogenic means where we as clinicians, we are inducing preterm birth. Why? Because suppose if your patient has PIH, severe preeclampsia. Now, all of you know that whenever there is severe preeclampsia, we say that pregnancy should be terminated at 34 weeks. Right? So that is an iatrogenic preterm birth, which we are doing because to avoid maternal risk and fetal risk. Right? So iatrogenic is when we are inducing preterm birth for maternal or for fetal well-being. This is not happening spontaneously, but we as clinicians are doing it, right? On the other hand, 80% of preterm births, they are your spontaneous preterm births, in which 40 to 50% preterm births are happening because of preterm labor, right? So a patient goes into preterm labor and eventually there is delivery. That is what is happening in 40 to 50% cases. In 20 to 30% cases, preterm birth is happening due to preterm premature rupture of membranes, right? And then, yes, rarely it can also happen due to cervical insufficiency, right? So this is the incidence for preterm birth. Now, as an undergraduate student or as a NEET PG aspirant, we just told you the risk factors for preterm birth, and that was all what you were supposed to know. But as a resident of OBGY, you need to understand in detail about the pathogenesis of preterm birth, Because once you understand the pathogenesis of preterm birth, you will understand the risk factors for preterm birth, and you will also be able to understand the interventions. What intervention am I going to do if I find my patient at risk for preterm birth, right? So that is very, very important to understand the pathogenesis of spontaneous preterm birth. Now, in pathogenesis, please understand that there are 4 major pathogenic processes which lead to preterm birth, right? And these 4 are, I'm going to explain each one of them in detail to all of you. Now, the first one is premature activation of fetal hypothalamic pituitary adrenal axis, right? So number 1 is premature activation of fetal hypothalamic pituitary adrenal axis. Now I'm sure when you were doing your undergraduate, and if you were a marrow student, you already know that fetal HPA axis plays a very, very important role in initiation of uterine contractions, right? All of you know that it is the fetal adrenal glands which are going to secrete DHEA sulfate, and this DHEA sulfate will be used as a precursor to produce estrogen. Placenta is going to use this as a precursor to produce estrogen, right? And it is this estrogen which in turn leads to increase in uterine contractions, and that leads to labor. So that is the normal mechanism of labor which you know from your undergraduate time. Now, if you even remember this much, I will be telling you all the details, but even if you remember this much, that yes, fetal HPA axis had some role in initiating labor, you will definitely understand this, that if fetal HPA axis is prematurely activated, it is going to lead to preterm birth, right? Although the details are going to come up, but I'm sure this much you would have understood by this sentence, right? Then second mechanism which leads to preterm birth is, the second pathogenic mechanism is exaggerated inflammatory response, right? Exaggerated inflammatory response or infection or an altered genital tract microbiome, right? So if there is an alteration in the vaginal flora, right? Third mechanism is if there is decidual hemorrhage, for example, in case of abruptio placenta. Example is abruptio placenta, right? Then number 4 is if there is pathological over distension of the uterus, right? So these are the 4 main pathogenic mechanisms which lead to preterm labor. Now we are going to go into the details of all these one by one. So the first one is premature activation of the HPA axis of the fetus. Now whenever there is stress can lead to premature activation of the HPA axis of the fetus. And when I say stress can lead to premature activation of HPA axis of the fetus, this stress, it can be maternal stress or it can be fetal stress, right? So maternal stress, when will be a mother in stress? So suppose if mother is having depression, or she's having anxiety, or if she's having chronic diseases, like if she's having hypertension, if she's having diabetes, if she's having anemia, if she's having kidney diseases, right? Or if she's having depression, anxiety, all these lead to maternal stress. And whenever there is maternal stress, what is going to happen? When there will be maternal stress, the hypothalamus in the mother is going to release CRH, corticotropin releasing hormone. Now this CRH, it is going to act on the pituitary, and from pituitary ACTH will be released, right? So whenever mother is in stress, that I have told you the various types of stresses which a mother can face. That this is going to lead to stimulate the hypothalamus, and from hypothalamus ACTH will be released, sorry, CRH will be released, and this CRH is going to act on pituitary and ACTH will be released. Now this ACTH is going to act on the adrenal glands to release cortisol. Now, one very important concept which you have to remember from your physiology is that this cortisol, which is released in the mother, it has got a negative feedback on maternal CRH and maternal ACTH. But when it comes to placental CRH, this cortisol has a positive feedback on placental CRH, right? So, mother's cortisol has got a negative feedback on her own ACTH and on her own CRH. But when we are talking about placental CRH, this is going to have a positive feedback mechanism on placental CRH. At this point, I also want all of you to know and to remember that in pregnancy, placental CRH is released. And from where is this placental CRH released? This placental CRH is released by trophoblast. It is released by the fetal membranes, that is amnion, chorion, and it is released by decidual cells. So these are the sources for placental CRH. What are the sources for placental CRH? Trophoblast, fetal membranes, and decidual cells. These are all sources for these placental CRH. Now, what does this placental CRH do? It is this placental CRH which is going to stimulate the fetal HPA axis prematurely. So, the fetal HPA axis is going to get prematurely activated because placental CRH will be released, right? Now, this is what is happening when there is maternal stress. Similarly, if there is fetal stress, right? For example, if there is uteroplacental insufficiency or if there is IUGR, in uteroplacental insufficiency or in IUGR, there is fetal stress. Now, this fetal stress is directly going to activate the fetal, prematurely activate the fetal HPA axis. Right? Now, once fetal HPA axis is going to be activated, again, the fetal hypothalamus is going to release CRH and it is going to, pituitary glands are going to release ACTH and fetal adrenal glands are going to release cortisol. So, whenever fetal plus HPA axis gets activated, there will be increased fetal cortisol. Right? And it is this increased fetal cortisol which will also have a positive feedback on placental CRH. Right? So, whenever fetal cortisol is released, that could be due to fetal stress, that could be due to maternal stress. Whatever may be the reason for release of this fetal cortisol, it is going to go back and it is going to have a positive feedback on placental CRH. That is one action which is going to happen when fetal HPA axis is going to be prematurely activated. That is one thing which is happening. The other thing which is going to happen is that there will be functional withdrawal of progesterone. There will be functional withdrawal of progesterone. Functional withdrawal of progesterone. Now, what do you understand by this term functional withdrawal of progesterone? Functional withdrawal of progesterone, you are going to hear this term during this entire lecture a number of times. That really doesn't mean that the levels of progesterone are decreasing. No. Functional progesterone simply means that the action of progesterone on its receptors is decreasing. Right? So, now the effect of progesterone is going to decrease, although the levels of progesterone are going to remain normal. So I am not saying that the levels of progesterone are decreasing. I am saying that there is a functional withdrawal of progesterone, which simply means that the action of progesterone is going to be less now. Now the binding of progesterone to its receptors is going to be less, right? Not only this, when the fetal HPA axis gets stimulated, again from the adrenal glands, what is going to be formed? From adrenal glands, DHEA sulfate is going to be formed, right? So when there is increased placental CRH, it is causing fetal HPA axis to get prematurely stimulated. So obviously the adrenal glands of the fetus are going to form DHEA sulfate. And when it is going to form DHEA sulfate, this DHEA sulfate is going to go in the placenta, and placenta is going to convert it into estrogen. Right? So fetal DHEA sulfate is going to get converted into estrogen. Now that means this estrogen is also prematurely being elevated. Now once this estrogen levels are prematurely getting elevated in case of preterm birth, what is going to happen? Whenever the levels of estrogen are increasing, what happens? Or the effect of estrogen increases. Estrogen binds more to its receptors. What happens then? Then there is increase in gap junctions. Number one. Number two, this estrogen leads to an increase in the number of oxytocin receptors. Number three, it is going to increase the activity of prostaglandins, and it is going to increase enzyme activity, right, which is responsible. It is going to increase the activity of those enzymes which are responsible for uterine contractions, right? For example, calmodulin, myosin light chain kinase. For example, enzymes like calmodulin and myosin light chain kinase. Myosin light chain kinase. Right? So these are the effects which estrogen is going to bring. What is estrogen going to do? Estrogen is going to increase the number of gap junctions. It is going to increase oxytocin receptors. It is going to increase the activity of prostaglandins, and it is going to increase activity of those enzymes which are responsible for uterine contractions like calmodulin and myosin light chain kinase. Right? Clear till here to all of you? Okay. Now, apart from this placental CRH, it is also going to, when the fetal HPA axis is going to get activated, this fetal HPA axis is going to release glucocorticoids and prostaglandins. Right? So fetal HPA axis, the fetal adrenal glands are going to release glucocorticoids, and it is going to release prostaglandins. Now this glucocorticoids and prostaglandins, what are they going to do? They are going to increase uterine contractions, and they are going to lead to cervical maturation. So they will increase uterine contractions, they are going to lead to uterine contractions, and they are going to lead to cervical maturation. Not only this, not only via fetal HPA axis, this action of increasing uterine contractions and of bringing about cervical maturation, this is directly done by placental CRH also. Right? So this is the entire cascade of events which happens when mother is in stress or when fetus is in stress. So quickly, I'm going to just tell you here, when mother is in stress, her hypothalamus is going to release CRH, which is going to act on pituitary, which is going to release ACTH, which is going to act on adrenals to release cortisol. This cortisol is going to have a positive feedback on the placenta, and placental CRH will be released, which is going to prematurely activate the fetal HPA axis. So now from the fetal adrenal glands, there will be increased fetal cortisol, which is again going to have a positive feedback on CRH, and there will be functional withdrawal of progesterone. Apart from this, there will be increase in formation of estrogen, and because there will be increase in formation of estrogen, this estrogen is going to increase the oxytocin receptors, and also it is going to increase the activity of prostaglandins, and it is going to increase enzymes which bring about uterine contractions. So whatever, please remember that all the mechanisms which we are going to talk about, in all the mechanisms there are certain things which you are going to get common, and that is the ultimate result in all of them is going to be common. In all the mechanisms which I am going to tell you, which are going to lead to preterm labor, you will have increase in oxytocin receptors, you will have increase in estrogen. Now that increase in estrogen could be in the levels of estrogen, it could be in the receptors of estrogen, right? There is going to be increase in prostaglandin levels, and there is going to be a functional withdrawal of progesterone. All mechanisms, ultimately all mechanisms are going to sum up to this. What is happening in preterm labor? All the pathogenic mechanisms, right? Now, if you've understood this much, there are just one or two more points which I want to point out here. Elevated circulating levels of estrogen, they are markers for spontaneous preterm birth. That is one very important point. So, if you are a NEET super specialty aspirant, please remember this, that one of the markers for spontaneous preterm birth is elevated circulating estrogen levels, right? So if you are measuring salivary estriol levels, and if it is increased, it has a high predictive value for late preterm birth, right? So these are two important points which can be asked from MCQ point of view to you in your super specialty exams. Now, second pathogenic mechanism which leads to preterm labor is exaggerated inflammatory response or infections. So first, very important question. Now, whether you are a resident or whether you are going to appear for NEET SS, you should be knowing what are the infections which may lead to preterm birth. So first and the most important infection which you have to remember is asymptomatic bacteriuria. That's number one. Number two is clinical or subclinical chorioamnionitis. Right? Number three, bacterial vaginosis, or that is an alteration in vaginal flora. Right? Then number four, trichomonas vaginitis. That is also a very important infection which leads to preterm labor. But on the other hand, if you have to choose one vaginal infection which is most commonly associated with preterm birth, then that one definitely is going to be bacterial vaginosis. So for all the NEET SS aspirants, please remember that one vaginal infection, if you have to mark, which is strongly associated with preterm birth, is bacterial vaginosis, although I am telling you that Trichomonas vaginalis also leads to preterm birth, but then bacterial vaginosis is more strongly associated. And surprisingly, malaria. Malaria infection is also associated with preterm birth. Now, please remember, Candida is not associated with preterm birth. So, one vaginal infection which is not associated with preterm birth is candidiasis. Right? Now comes the important question that how infections can lead to preterm birth. Now, infections, how can they lead to preterm birth? Number one, there are some direct effects because of which they can lead to preterm birth. Then because of inflammation, they can lead to preterm birth. And number 3, because of the release of certain enzymes, they can lead to preterm birth. So what are the direct effects? The direct effects are bacteria. These bacteria, they produce phospholipase A2 enzyme. And this phospholipase A2 enzyme, it increases prostaglandins. It increases the levels of prostaglandins. And just now I told you that, ultimately all the mechanisms are going to sum up to this, that there is going to be increase in prostaglandin levels. And whenever there is an increase in prostaglandin levels, definitely it is going to lead to preterm birth. Number 2 is that bacteria, they produce endotoxins. And it is these endotoxins which is going to stimulate uterine contractions, right? So number 1 mechanism, direct mechanism, is they release phospholipase A2, and this phospholipase A2 directly, it is going to increase prostaglandins, and because it is going to increase prostaglandins, there will be uterine contractions. Number 2, they release endotoxins, and because they release endotoxins, then again it is going to stimulate uterine contractions. Number 3 is organisms like Staphylococcus and Pseudomonas. Pseudomonas and Staphylococcus, they produce enzymes like protease and collagenase. And all of you know that if enzymes like protease and collagenases are produced, it is going to lead to degradation of fetal membranes, and it is because of the degradation of fetal membranes that there will be preterm, premature rupture of membranes, and this in turn is going to lead to preterm birth or preterm labor. Are you understanding? So this is one set of mechanism by which preterm birth can happen due to inflammation or due to infection. Because of the production of phospholipase A2, because of production of endotoxins, and because Staphylococcus and Pseudomonas, they can produce collagenase and protease, which is going to degrade the fetal membranes, and then that is going to lead to PPROM and preterm birth or preterm labor, right? Now, next is the inflammatory, because of inflammatory response. Now, how inflammatory response leads to preterm birth is the bacteria ligands, they are going to bind to receptors, and these are special receptors which are called as toll-like receptors, TLR, right? So whenever there will be any infection, the bacteria is going to bind to these toll-like receptors which are present on decidua, which are present on chorion, amnion, and on leukocyte membrane. Now, the moment these bacteria, they bind to these toll-like receptors, TLR receptors, which are present on fetal membranes, which are present on decidua, they are going to release inflammatory markers. So they are going to release interleukin-1 and tumor necrosis factor. And once this interleukin-1 or tumor necrosis factor is released, it is going to activate the COX-2 enzyme, and so there will be increase in prostaglandin levels, and it is going to lead to a physiological withdrawal of progesterone, right? So this is what happens when inflammatory mediators are released. So why are these inflammatory mediators? These bacteria are going to activate the COX-2 enzyme, and they are going to release prostaglandins, and they are going to lead to a physiological withdrawal of progesterone, right? Then third mechanism is they release certain enzymes like matrix metalloprotein. And when they release enzymes like matrix metalloprotein, this matrix metalloprotein is going to again degrade the fetal membranes, and because it is going to degrade fetal membranes, it is going to lead to PROM, and this PROM will eventually PPROM or PROM, and this is going to lead to preterm birth. Not only this, matrix metalloprotein enzyme, proteinase enzymes, the MMP enzymes, they also promote uterine contraction. So ultimately, as I told you, this is what is going to happen. That there will be physiological withdrawal of progesterone, there will be increase in prostaglandin levels, the membranes are going to rupture, there will be increase in estrogen, there will be increase in oxytocin receptors, and that is what we are witnessing. But what is important is you may get a question, a short note on pathogenesis of preterm birth, and that is when you are going to explain in detail all this, right? Okay. Then comes the third mechanism, and that is decidual hemorrhage. Now, suppose a female has bleeding, pregnant female has bleeding in pregnancy. Now, that bleeding could happen in first trimester, it could happen in second trimester, or it could happen in third trimester. Now, especially if there is a third trimester bleeding, like if there is a case of abruption or placenta previa, that definitely leads to preterm birth. That is one of the very important reasons. I'm not saying that all these cases will lead to preterm birth, but they are very important risk factors for preterm birth. But please remember that bleeding in first trimester is also an important reason for preterm birth. Although, yes, the chances of preterm birth are more if vaginal bleeding is experienced after the fetus attains viability. Then the chances are more for it to end up into preterm birth. But then any kind of vaginal bleeding which happens is a risk factor for preterm birth. Now, whenever there is vaginal bleeding which is happening, what actually leads to preterm birth is, whenever we say that there is vaginal bleeding, it is going to lead to decidual hemorrhage. And it is this decidual hemorrhage which leads to preterm birth. How? So let's take the example of abruption. Now, whenever there is going to be abruption, what is going to be released? All of you know that whenever abruption happens, then thrombin is released. Right? So it is going to lead to the release of thrombin. Now this thrombin is going to bind to PAR receptors, protease activated receptor 1 and protease activated receptor 3. So this tissue thrombin, initially there will be tissue thromboplastin which will be released, which is going to get converted into thrombin, and this thrombin is going to bind to PAR receptors, which PAR1 and PAR3. Now the moment thrombin binds to these receptors, these receptors are present on the uterus as well. So it is going to lead to increase in uterine contractions. Right, so it is going to directly act on the uterus and it is going to cause uterine contractions. There will be increase in the frequency, there will be increase in strength, and there will be increase in the tone of contractions whenever thrombin is released. Right? Second thing which is going to happen is, this thrombin, whenever it is released, it is going to lead to an increase in matrix metalloproteinase enzyme. And just now I told you that whenever matrix metalloproteinase enzyme is released, what does that do? It degrades the fetal membranes. So that can lead to PPROM and that can lead to preterm birth. And number 2, I told you that matrix metalloproteinase enzyme in itself increases uterine contractions, right? Then what else does this thrombin do? This thrombin, again, it is going to lead to a functional withdrawal of progesterone, right? And it is going to induce interleukin 8 from the decidual cells. It is going to induce the release of interleukin 8 from the decidual cells and from the fetal membranes, right? Because of this interleukin 8, which is an inflammatory marker, when it is going to be released, there is going to be neutrophilic infiltration, right? And when there is going to be neutrophilic infiltration, again there will be degradation of the fetal membranes, right? So that is why in case of abruption, even though inflammation is not happening, still on histopathological examination you get dense neutrophilic infiltrates. This is the reason why, because thrombin is released, and that thrombin induces interleukin 8 to be released from decidua and from fetal membranes. And because of this release of interleukin 8, there is dense neutrophilic infiltration, and this dense neutrophilic infiltration then ultimately leads to degradation of the fetal membranes, right? And again, that is going to result in preterm birth. Clear to all of you, right? So that was the third mechanism, that how decidual hemorrhage or abruption is leading to preterm birth, right? I hope all of you are understanding, and I'm going at a pace where you are able to understand. So if you can just mention it in the chat box, I'll be glad. I'll get an indication that all of you are with me and you are understanding. See, I am not, as I told you, this session is purely for residents. So I'm not going to answer your questions for FMGE. I'm not going to answer your questions for NEET PG and for Marrow. So if you are residents who are attending my lecture, just give me some indication that you people are understanding. Put a thumbs up so that I come to know. Okay. So not just to cure, but to heal. Oh, that's a very nice name. So we have Shreya, you are understanding. Rasool, you are understanding. Ruchita, Patil. Okay. Ruchita, you want me to slow down my speed? Beta, I can slow down my speed, and I will try to slow down my speed. The problem is that then you might feel exhausted, because this lecture anyways is going to be around 2.5 to 3 hours. So just in case, my advice to you is try to understand what I'm telling you just now. Note as much as possible just now. If in case something you are missing, then this lecture is going to stay on YouTube. So then you can, later on you can copy whatever you want to copy from the notes. I understand, Ruchita, because you are making notes. I'll try to slow down. I'll go by what you people say. I'll try to slow down. But you also understand that if you are missing out on anything, just leave that space blank and come again once the lecture ends and fill up those blanks, right? This was very, very theoretical, which I was teaching, so very difficult to understand. We will have a very interesting talk on preterm labor just now. This is the very theoretical part of preterm birth, but I promise you, as we progress, preterm birth is really an interesting topic, right? Okay. This is the only theoretical part which is there in preterm birth. Rest everything is so interesting in preterm birth, because there are guidelines that when you should be using tocolysis, when you should be using corticosteroids, that all of you are going to enjoy this topic. So bear with me the theoretical part just now, right? Okay. Then comes pathological uterine distension. Again, pathological uterine distension, like it happens in twins, right? Like it happens in polyhydramnios, that can lead to preterm birth because it leads to stretching of the myometrium. Now, whenever there is going to be stretching of the myometrium, what is going to happen? Number one, there will be formation of gap junctions, right? Number two, there will be increase in oxytocin receptors. Number three, there will be release of prostaglandins, right? There will be release of prostaglandins, and as I told you, whenever prostaglandins are released, they lead to cervical maturation and uterine contraction, right? Why prostaglandins do this? Because prostaglandins in turn, they activate enzymes like calmodulin and myosin light chain kinase, right? Then number four, because of stretching of myometrium, there is overexpression of genes, right? And when there is overexpression of genes, which genes? Those genes which are which are going to activate collagenase enzyme, right? And they are going to bring about inflammation. So there will be overexpressions of gene which are going to ultimately activate the collagenase enzymes. Those genes which activate collagenase enzymes, there will be overexpression of those genes, and those genes which bring about inflammation, there will be overexpression of those genes, right? That is how pathological uterine distension, it leads to a preterm birth. Clear? Okay. So that theoretical part is over now. Now comes whether you are asked in your theory or whether you are asked in your viva, or you may get a case of preterm birth. Right now, whenever such a patient comes to you, you have to know the risk factors for preterm birth. So all these things which I have told you, all the pathological mechanisms which I have told you just now, are going to help you understand the risk factors. For example, first pathological mechanism which I told you was premature activation of the fetal HPA axis. And why was that happening? That was happening because of stress, maternal stress, like anxiety, like depression, like chronic medical diseases. Then fetal stress, like UPI, like IUGR. So all these are risk factors for preterm birth. Second, I told you infections. So all infections which I made you write down, all of them are risk factors for preterm birth. Third thing which I told you was vaginal bleeding. So whenever you get a case of preterm birth, you specifically have to ask them that did they experience any episode of vaginal bleeding in their first trimester or second trimester, or is she a known case of placenta previa. You also have to rule out abruption in all patients who come to you with preterm birth. And number 4 is uterine distension. Now, not only these, there are many other factors, risk factors, which lead to preterm birth, and that we are going to do in the form of case history. Right? What are the specific case histories which you are going to take in a patient of preterm labor, and how are you going to, what all are you going to keep in mind with respect to the risk factors, that you don't miss out on any of those risk factors. Remember them in the form of this the history format, so that this helps you in your viva also, and this helps you whenever you are writing a detailed answer also. First important thing in a case of preterm birth, whenever you have to present a case of preterm birth, is socioeconomic status. Has socioeconomic status any relation with preterm birth? Yes. Low socioeconomic status females, they have increased chances of preterm birth, right? Why? Because when there is low socioeconomic status due to undernutrition, there are increased chances of preterm birth. So one of the important risk factors for preterm birth is also undernutrition, right? Second thing, has age anything to do with preterm birth? Please remember that if pregnancy is happening too early or too late, that means if pregnancy is happening in young females who are less than 17, in them also the chances of preterm birth are increased. Why? This happens because of their physiological immaturity, right? Because of their physiological immaturity, there will be a lot of stress in such females when they become pregnant. And just now I told you, maternal stress leads to premature activation of HPA axis, and that leads to preterm birth. So age also has a relation to preterm birth. Not only this, if you have got females who are pregnant who are more than 35 years of age, again, there are increased chances of preterm birth in them because of two reasons. Number one, because of chronic medical diseases. So all the chronic medical diseases, they are going to be more in females who are more than 35 years. And number two, such females are obese. So not only undernutrition, but obesity in itself is also a risk factor for preterm birth. Young age at which a female conceives, or if she's conceiving at, so both the extremes of age, Young age and more than 35, both are risk factors for preterm birth, right? So third thing is you should be noting their weight, right? Weight of the patient is very important. So whenever you are presenting a case of preterm birth, do not forget, although yes, she's a pregnant female and definitely you are going to take the weight of that patient, but then specifically in preterm birth, the examiner can ask you that is there any relation why weight is very important in a case of preterm birth. So remember that obesity in itself is a risk factor for preterm birth. Why? Because it induces inflammatory state. Right? So because it induces in an inflammatory state, it is a risk factor for preterm birth. Then race. Has race any relation? Yes. Preterm birth is more common in African Asian females. So African Asian females, they have a higher risk for preterm birth. So these are important factors, general factors, which you should be keeping in mind. You should know about the socioeconomic status, about the age, the relation of age to preterm birth, relation of weight to preterm birth, and race to preterm birth, right? So indirectly, we are doing all the risk factors related to preterm birth. Then family history. Now, please understand that family history is also very important in preterm birth. Why? Because there are genetic factors which play a role in preterm birth. And what genetic factors? One very important genetic factor which you have to remember is gene WNT4, right? So yes, preterm birth has a genetic predisposition also, and there are various genes. I don't want you to remember all those genes. One important gene which you can remember is WNT4 gene. So whenever you are taking history from a patient of preterm birth, you have to specifically ask her about her maternal preterm birth history, right? That whether her mother had a history of preterm birth. Not only this, you also have to ask about preterm birth in sister. So whether her sister has had any preterm birth, right? Okay. Then comes dietary history. Again, dietary history is very important. As I told you, undernutrition and obesity. Both of them are risk factors for preterm birth. Then occupational history. Again, occupational history is very important when you are presenting a case of preterm birth, because if a female has long working hours, see, all those data which we have, all those studies which we have, they have been performed abroad. They have been performed in countries, in very developed countries, where there are limited number of working hours. And in those countries, it was seen that if there is long working hours, and for them long working hours is more than 80 hours in a week, or if a female has a job profile where she has to stand for long hours, right? And in those countries it was seen, in those studies it was seen, that if a female is standing for more than 4 hours in a day at a stretch, if she's standing for more than 4 hours in a day, then the chances of preterm birth are increased. So long working hours, or at a stretch if a pregnant female stands for more than 4 hours. And definitely that is the reason why so many doctors, so many female doctors, and you will also see that amongst you people, female doctors, senior residents and junior residents, your friends who conceive, they have increased chances of preterm birth, not only because of stress, but because of the long working hours, because of the long standing hours which we have to face. Then you have to take history of substance abuse. Why? Because smoking, cigarette smoking is one of the very important risk factors for preterm birth, and cocaine abuse. These are two histories, which is substance abuse histories, which you have to take. But please, although we know that whenever a female is going to conceive, you will have to advise her to stop smoking and to stop using cocaine. But we really don't know that if they are going to stop using smoking, if they are going to stop smoking, or if they are going to stop taking cocaine during pregnancy, will it have a positive result on their gestational age at which they are going to have birth or not, right? So the note is, even if a pregnant female stops smoking, whether it will prevent preterm birth or not, we don't know. But definitely we are going to tell her to stop smoking, right? So this is what you're going to do in general. Then general history, what you are taking, family history, what you are taking, dietary, this is you're going to keep in mind, occupational history, and substance abuse history. Apart from that, in past history, what is important? The most important risk factor you are going to ask her about, that is previous history of preterm birth. This is the most important risk factor for preterm birth. If the female herself has a previous history of preterm birth, that's the most important risk factor. If there is previous history of one preterm birth, then the recurrence rate is 15 to 30%. And if there is previous history of two preterm births, then the recurrence rate is 60%. Right? Number two, you are going to take history of any chronic medical diseases, like you are going to take history of diabetes, whether she is having diabetes or not, whether she has any renal disease, whether she is suffering from any depression, anxiety, autoimmune diseases. So all these histories you are going to take. Number three, you are going to take history of surgical abortions. It is seen that if a female has undergone surgical abortion, that means if you have done suction evacuation or dilatation and evacuation in any female earlier, right, then they have increased chances of preterm birth in their next pregnancy, right? So surgical abortion, it is linked to preterm birth. But on the other hand, if there has been a spontaneous abortion, right, so or if there has been an abortion where you had given medical drugs, right, so if there is previous history of medical abortion, so if there is previous history of medical abortion, then that is not linked to preterm birth. Right? So previous history of surgical abortion is what is linked to preterm birth. Then you are going to take previous history of any previous cervical surgery which the female had undergone. For example, conization or LEEP. Why? Because just now I am going to tell you in detail about short cervix. Short cervix is a very, very important risk factor for preterm birth. Right? So you have to take history of any previous cervical surgery which the female might have underwent. Then you are going to take history about any uterine anomalies. For example, septate uterus and bicornuate uterus, and also about fibroids. Right? So these are the histories which you are going to take. Now, why is it that a fibroid can lead to a preterm birth, and how is it possible? See, when a fibroid is present, then the uterine contractions get increased. You know, whenever a fibroid is present, uterus undergoes a lot of spontaneous uterine contractions, and because of these uterine contractions, there are increased chances for preterm birth. Right? So you have to take history of any, whether she is a diagnosed case of fibroid or whether she is a diagnosed case of septate or bicornuate uterus. Right? So this is the past history which you have to take. previous history of any preterm birth, previous history of any chronic medical diseases, previous history of any surgical abortion which she might have underwent, previous history of any previous, cervical surgery which she may have underwent, or previous history of any uterine problem, which could be a congenital problem like septate or bicondylitis uterus, or it could be an acquired problem like fibroid uterus. Right? Now you are also going to ask her about her present pregnancy. Now there are certain things which you have to keep in mind which may lead to preterm birth, which manifest in present pregnancy. For example, if this present pregnancy is through assisted reproductive techniques, right? So if the present pregnancy is through ART, that is an independent risk factor for preterm birth. One of the reasons why ART can lead to preterm birth is because of multifetal gestation. And when there will be multifetal gestation, there is going to be uterine overdistension, and that is going to lead to preterm birth. But then apart from that, even if it is not a multifetal gestation, even if it is a singleton pregnancy, and that singleton pregnancy is happening as a result of ART, ART is an independent risk factor for preterm birth. Number two, very, very important thing which you have to ask this female is about her inter-pregnancy interval, right? So suppose, see, the ideal inter-pregnancy interval, ideally the inter-pregnancy interval should be 18 months, right? Or it should be at least 12 months. Right? So this is very important. Females with short inter-pregnancy interval, they have increased chances of preterm birth. Right? Then multifetal pregnancy. Yes, if this pregnancy is a twin pregnancy or a multifetal pregnancy, you know that due to uterine overdistension, there is going to be preterm birth. Then if there has been, you are going to ask her if there has been history of vaginal bleeding in this pregnancy. If in this pregnancy female has had vaginal bleeding, whether it has happened in first trimester, whether it has happened in second trimester, or whether it has happened in third trimester, all of it is a risk factor for preterm birth. Then you are going to take history of infections, right? For example, you are going to take history of any vaginal discharge which she might be experiencing, right? So infections, you have to take history of infections. Then about short cervix. Now short cervix, you cannot take history of short cervix. I am going to tell you in detail about short cervix, but I have mentioned it over here so that you remember it as one of the risk factors. You cannot take any history related to short cervix except for the history of abortion, second trimester abortions. Now, how does short cervix lead to preterm birth? Number one, whenever there is short cervix, there will be loss of tensile strength of the cervical stroma. Number one, in case of short cervix. Number two, there is loss of cervical plasticity. And number three, there is increased susceptibility to infections. For example, if there is history of previous cervical surgery which has led to a short cervix, then this is one of the mechanisms which come into play, that there are increased chances of infection, right? And in order to detect females with short cervix, you do a TVS between 18 to 20 weeks, right? So, this is what you do. We are going to talk in detail about short cervix just now. Now, are there any paternal factors which are risk factors for preterm birth? No. None of the paternal factors are risk factors for preterm birth. Are there any fetal factors which are risk factors for preterm birth? Yes. Number one, IUGR. Just now I told you IUGR can lead to fetal stress. Number two, congenital anomalies. Now, in IUGR and in congenital anomalies, not only in IUGR, not only the chances of spontaneous preterm birth are increased, but In IUGR and in congenital anomaly, the chances of um, iatrogenic preterm birth are also increased, because if there is going to be IUGR, you are going to terminate her pregnancy before 37 weeks. Similarly, if there are congenital anomalies, you are going to terminate the pregnancy before 37 weeks. So congenital anomalies and IUGR are also, risk for preterm birth, for iatrogenic preterm birth. And then it is seen that male sex, if the fetus is male sex, then there are also increased chances for preterm birth. Right? Clear to all of you? Are they, Dr. Zoya, you are saying, are they continuous abortion or abortions occurred at any time by surgical? Dr. Zoya, what do we mean? I am not understanding your question, what you are saying as continuous abortions. Any time a female had an abortion, right? And that abortion was managed surgically. So basically, it is MTP. If you did suction evacuation, if you did MTP by surgical methods, then that is a risk factor for your preterm birth, right? Have you understood, Dr. Zoya? Any other question which you have till now? No? I am just waiting so that whatever queries you have till now, I will clear them, and then we are going to go to important interventions which you can do to prevent preterm birth, right? So just now we are talking about preventing preterm birth. Ruchita, what is responsible for PLB? I didn't understand this, what you're asking me. Ruchita, I am not understanding your question. If you can write nicely or clearly what you want to ask me, I'll tell you. Any other questions? No? Okay. So let us proceed. So just now we haven't talked about a female who is in preterm birth. No, we have not talked about preterm labor just now. Just now we are talking about, if a female comes to you with preterm birth, what are the histories which you are going to take? Or the other way of asking this question is, in your theory paper, they can ask you what are the risk factors for preterm birth and what are the important interventions which you are going to do to prevent that preterm birth. Dr. Vignesh, no, there is no reason for why a male baby can predispose to preterm birth. There is no reason for that, right? Okay. Uh, Ruchita, that is what I said just now. There is no specific reason for that. It is just a casual association which was seen, that most of the preterm births, when we saw them, we saw that they had male fetuses. So probably, one of the risk factors for preterm birth could be a male fetus. But then that comes last in your list. If you are telling risk factors for preterm birth, you are not going to say first male fetus, right? And then be in trouble. No, that is going to be last, last in your list, that yes, some relationship has been seen, which we don't know that why all most of the preterm births which have happened, coincidentally, they had male fetuses more than female fetuses, right? Clear to all of you? Now, the two very important interventions to prevent preterm labor are progesterone, right, and cervical cerclage. So this is one topic which you need to really understand, that where you have to give progesterone. This is important as a clinician also. You should be knowing what progesterone you have to give to your patient, when you have to start progesterone, and in which patients is this progesterone going to be beneficial. So many times in your hospitals, so many times in your clinics, you are going to see that there is irrational use of progesterone. Every patient who comes to us with even slightest of contractions, we write down progesterone. But then that is not where progesterone should be used. I'm going to tell you where you are going to use progesterone, and in those cases where the role is doubtful, and those cases where you shouldn't be using progesterone, right? So this again is very, very important. Uh, Madhav, you have a class today at 10 p.m. So don't worry, for NEET PG also, I have a class today at 10. Okay, coming to progesterone. So quickly, let us go and talk about progesterone now. Now, progesterone, number one, when we give progesterone supplementation, it is seen that it helps to reduce preterm birth, but then it is not the ultimate solution. Right? Any female who comes to us with preterm birth, you are not going to irrationally give her progesterone. Why? Because when we see that when progesterone is given, then it will decrease the risk of preterm birth by 20%. So if all females who had to go into preterm birth, right? I have 100 females who I know are going to go into preterm birth. If I give them all these 100 females, if I give them progesterone, I see the result is that only in 20 of them, the preterm birth is going to be prevented, right? That is what is meant by it decreases the risk of preterm birth by 20% if all pregnant females who are to go into preterm birth are given progesterone. And if you see the absolute risk, what is the absolute risk which is decreased? So it decreases absolute risk by only 0.02%. Right? This is because not all preterm births have previous history of preterm birth or short cervix. In other words, I am telling you that progesterone is going to be useful only in these two conditions. If preterm birth is happening due to and the female has previous history of preterm birth, and you are using progesterone, right? Then yes, the use of progesterone is beneficial and it is going to prevent preterm birth in her in this pregnancy. So if I have a pregnant female, suppose I have 4 pregnant females, in one pregnant female, the risk factor is that previous history of preterm birth, right? In second female, the risk factor in this pregnancy which may lead to preterm birth is short cervix. In third female, the risk factor is that she has conceived due to ART. And in fourth female, the risk factor is she is obese. All these 4 are individually risk factors for preterm birth in this pregnancy. Right? Now, in all these 4 females, if I give progesterone, what we notice is that progesterone is going to prevent preterm birth only in first and second female. Only in that pregnant female in whom there is previous history of preterm birth, or in that pregnant female who in present pregnancy had short cervix. Only in these two cases the role is well defined, and I know that 100% it is going to prevent preterm birth in these females, right? But not in the other two category. So that is what I have written, that it is decreasing the absolute risk of preterm birth only by 0.02%. This is because not all preterm births have risk factor of previous history of preterm birth or they have short cervix, right? You will understand this as I proceed. Okay. Then what is the rationale for using progesterone? Now, all of you know that progesterone is a smooth muscle relaxant. This is something which all of you know, right? So, the rationale for progesterone supplementation is that when we give the endogenous progesterone, it has a smooth muscle relaxing effect. So, my pen is not working, just hold on. The charging is there. Okay, so I am not able to write over here. I'm just I cannot write because this is a pic, so just understand. Okay. And I'm enlarging it so that all of you can better copy. So, what is the rationale behind using progesterone? Number one is the rationale behind using progesterone is that endogenous progesterone is a uterine muscle relaxant, and endogenous progesterone, they act by binding to progesterone receptors. And we see that in entire pregnancy there is a maintenance of this progesterone levels, right? These progesterone levels are very nicely maintained. Initially, in early part of pregnancy, it is corpus luteum which is forming progesterone, right? And later on it is placenta which is forming progesterone, and ultimately this progesterone is keeping the uterine activity into control, right? And we also know, just now we saw that whenever labor process has to begin, there is a functional withdrawal of progesterone, right? And that means that labor is going to begin only when the levels of progesterone, we are not just talking about levels of progesterone, it is when the activity of progesterone decreases, right? When the receptors, when the progesterone is not binding to its receptors more tightly, then there is a functional withdrawal of progesterone, and this functional withdrawal of progesterone leads to labor. Whether it is preterm labor or whether it is term labor, there has to be a functional withdrawal of progesterone, then only this action is going to happen, right? So, number one, because in endogenous progesterone, it helps to keep the uterus in a relaxing mode. Number two, labor is going to happen only when there is a functional withdrawal of progesterone. So, these are rationales why we are using progesterone to prevent preterm birth. Number three, there is progesterone related immune modulation, and this progesterone related immune modulation, it may act to counter the inflammatory pathways, right? So this progesterone mediated immune modulation is going to have a counter effect on the inflammatory pathways, and that is the rationale behind using progesterone. That tells us that why we can use progesterone to prevent preterm births in certain cases. But then there is a counter finding also, and the counter finding says that already the circulating levels of progesterone in third trimester are very high, right? And they are so high that they are likely to saturate the progesterone receptors. So it is unclear that why exogenous supplementation might have biological effects. That's the counter, counter mechanism which is said, that counter debate which is given, that why we are using progesterone. Some say that yes, you have to use progesterone and these are the reasons why you should be using progesterone, and some say no, we don't know, we don't have evidence that by using progesterone the chances of preterm birth are going to be less, because already the progesterone levels are high in third trimester and already the receptors are saturated. So when you give exogenous progesterone, how is it going to act on the receptors and how more uterine relaxation it is going to bring? Right? But undoubtedly what we are clear on is we don't know that why exogenous progesterone when given decreases the chances of preterm birth, but then we know there are certain definitive indications for using progesterone. There are certain cases of preterm birth, females at preterm birth, in whom if you give, females who are at risk of preterm birth, if you give progesterone, the chances of preterm birth will be decreased. And what are those category of females? Number one, if there is previous history of spontaneous preterm birth, and number two, if in present pregnancy she has short cervix. Just now I told you, I gave you the example of 4 females, and I told you if first female she has a risk factor and that risk factor is previous history of preterm birth, then if you give progesterone to this female, then that is a definitive indication for giving progesterone, then the chances of preterm birth are decreased, right? Number one. Number two, short cervix. These two are clear cut indications for giving progesterone, right? So this is how you can prevent. Just now I'm not talking about treatment of preterm birth. I am talking about prevention of preterm birth, and one method which I'm talking about is progesterone, right? That how can progesterone be in what category of females can progesterone be given to prevent preterm birth? And first thing what I told you was that what is the incidence by which the preterm birth is decreased when you use progesterone, and the absolute risk is decreased by 0.02%. Then what is the rationale for using progesterone? I have told you the rationale for using progesterone, and I told you what is the counter finding, what is the counter debate for it, right? Then I am telling you what are preterm birth. In such females, you are going to give hydroxyprogesterone caproate, which in short can be written as 17-hydroxy-PC, right? So you are going to give 17-hydroxyprogesterone caproate 250 milligrams intramuscularly weekly. And this you are going to begin from 16 to between 16 to 20 weeks. You are going to begin it, and you are going to continue till 36 weeks of pregnancy. So if you have a pregnant female who has previous history of preterm birth, between 16 to 20 weeks, you should put her on progesterone. What progesterone you are going to put her? You are going to put her on hydroxyprogesterone caproate injections, 250 milligrams IM injections weekly, which you are going to start between 16 to 20 weeks, and you are going to continue till 36 weeks of gestation. 17-hydroxyprogesterone caproate is approved by FDA. It is a synthetic progesterone which has got minimal or no androgenic property, and the doses, they range from 25 milligrams every 5 days to 1000 milligrams weekly. So the range is 25 milligrams you give initially, every 5 days, or you can go up till maximum, you can go up till 1000 milligrams weekly. But normally in general practice to our patients, we are giving 250 milligrams IM injection weekly, right? Now, apart from this synthetic progesterone, you can also use natural progesterone or micronized progesterones. Now, natural progesterone, it can be administered vaginally, right? That is also an option which you can use in these patients, right? Now, along with this, in these patients, if you have history of spontaneous, whenever you have history of spontaneous preterm birth, in these patients, you should do serial ultrasound examination, which should start from, I'm just now going to tell you, in some cases, you are going to start them from 14 weeks, in some cases from 16 weeks. We will talk about that. But generally, between 14 to 16 weeks, you are going to start them. You are going to do serial ultrasound examination until 24 weeks. And if in any of these patients, you find that the cervix is short, it is less than 25 millimeters, or if cervical dilatation has occurred, then without the patient going into labor, patient is experiencing weak contractions or no contractions, and you see that the cervix is dilated, then you do a cervical cerclage. I will be talking about this just now. So I am telling you, whenever you have a patient who comes to you with previous history of preterm birth, definitely you have to put them on progesterone starting from 16 weeks, right? And then simultaneously weekly, what you are going to do is you are going to do ultrasound in them. Just now, don't write the exact protocol. Just now write only this much, because exact protocol I'll make you write just now, right? So you are going to do ultrasound examination in them, and if cervix is less than 2.5 centimeters, that is 25 millimeters, you are going to do a cervical cerclage. Clear to all of you? Yes? Okay. Now, suppose you have a second category of female. The second category of female is, this female is pregnant. She doesn't have any history of preterm birth, but then on routine screening for cervical length, you came to know that she has short cervix in this pregnancy. So as I told you, progesterone is going to be helpful in two conditions only. If a pregnant female has previous history of preterm birth, then you have to give progesterone. Or if she has short cervix in this pregnancy, then you have to give progesterone. So if you have a pregnant female in whom there is short cervix, now again you have to give progesterone, but now the preferred progesterone which I want to give her is natural progesterone, 100 milligrams vaginally daily. So daily I am going to give her 100 milligrams of vaginal progesterone beginning at the time of the diagnosis and continuing it up till 36 weeks plus 6 days. So if there was previous history of spontaneous preterm birth, I was giving her hydroxyprogesterone caprate IM weekly injections. Your alternative is a natural progesterone which you can advise her daily. But then if your patient has history of short cervix, then we do not prefer hydroxyprogesterone caprate injections. Then we prefer natural progesterone. Why? What is the difference in reproductive effect of 17-hydroxyprogesterone caprate and natural progesterone? See, natural progesterone is very, very effective in decreasing myometrial contractility and in preventing cervical ripening. How? Because natural progesterone, they have greater affinity for progesterone receptors than 17-hydroxyprogesterone. Number one reason. Natural progesterone will have a greater affinity for the progesterone receptors in comparison to synthetic progesterone, which is your hydroxyprogesterone caprate. Number two, the second advantage is when you are giving vaginal progesterone, natural vaginal progesterone, it will have a higher uterine bioavailability. Why? Because uterine exposure is going to occur before the first pass through the liver. So if you are giving in IM injections, you are giving then when you are giving IM injections, then this progesterone is going to undergo first pass metabolism in liver and then it is going to reach the uterus. But if you are giving vaginal progesterone, it is going to first go into the uterus. So the bioavailability in the uterus is going to be more, and that is why it is much better if patient has short cervix in this pregnancy. So if a patient has short cervix in this pregnancy, we prefer vaginal progesterone. Now the dose which I am going to begin with is 100 milligrams daily. And I may take her up to 200 milligrams, and maximum what you can give vaginally is 400 milligrams per day. Right? Clear to all of you? Is it clear that when are you going to use weekly IM injections and when you are going to use progesterone vaginally? Clear to all of you? So if it is clear, just show me a sign there. Show me a thumbs up sign. I am waiting for you. Oh, great. So I have got one sign indicating that you people are understanding. Ruchita, Zoya, are you still there? Are you understanding? Vignesh, Ruchita, Zoya, Vignesh, are you there? Vignesh, we can prefer vaginal progesterone in the previous history of preterm birth, but there I was telling you both the options are reasonable. You may go for hydroxyprogesterone caprate or you may go for vaginal progesterone, right? But what specifically I want to tell you is in this particular case, where you have a female has short cervix, I am not going to prefer hydroxyprogesterone caproate. Right? Okay. Now these were the two very clear-cut uses of progesterone, right? Where progesterone can be used to prevent preterm labor. Now we have possible uses of progesterone. Number one is multi-fetal gestation. Now, a very important concept which you have to understand in multi-fetal gestation is that progesterone is not effective in reducing spontaneous preterm birth in multi-fetal pregnancies as much as it can do in a singleton pregnancy. So in a singleton pregnancy, progesterone जितना effective है, उससे less effective it is when you are using it in multifetal pregnancy. Reason is that the pathogenesis of preterm labor and delivery in multifetal gestation is different from that in singleton pregnancy. Right? And we know that in multifetal pregnancy, preterm birth is happening due to uterine distension. Right? So the pathogenesis is very, very different. From in a singleton pregnancy, why preterm birth is happening, and in multifetal gestation, why preterm birth is happening, the pathogenesis is different. Number two reason why progesterone is not that helpful in multifetal pregnancy is that already the endogenous progesterone levels are higher in multifetal pregnancy as compared to singleton pregnancy. Right? So that is why in a multifetal pregnancy, if you give exogenous progesterone, then the effect might not be that much, right? Because already the levels of progesterone are high, right? So because of these two possible mechanisms, we understand that in multifetal pregnancy, progesterone is less effective in comparison to a singleton pregnancy. So if you have a multifetal pregnancy or a twin pregnancy with previous history of preterm birth. So in this pregnancy, patient has twin pregnancy and she had previous history of preterm birth, then yes, there is a possible role of progesterone. It may help. Now, similarly, if in this pregnancy patient has twin pregnancy or a multifetal pregnancy and she has short cervix, then also there is a possible role. But all of you know that multifetal pregnancy in itself is a risk factor for preterm birth. So suppose if there is a multifetal pregnant female, twin pregnancy ki female hai, she doesn't have any history of preterm birth, she doesn't have short cervix. But as such, multifetal pregnancy in itself is a risk factor for preterm birth. So in this category of female, is progesterone supplementation going to be helpful? No. Right? So there is no role of progesterone if in twin pregnancy there is no history of preterm birth and the length of the cervix is normal. Clear to all of you? Yes, possible role is only if she has history of preterm birth or if she has a short cervix in this pregnancy. Now suppose another female. This female, this time she has a singleton pregnancy, but she has previous history of twin pregnancy with preterm birth. Yes, then there is a possible role, right? So if previous history was a twin pregnancy with a preterm birth, then in this pregnancy, there may be a role of giving progesterone. Progesterone may be helpful in such females. So where I say possible role, that means giving progesterone may be helpful in them, right? Now, please understand that there is no role of progesterone if preterm labor has already happened. So if the process of labor has already started, so if you've made a diagnosis of preterm labor, then progesterone has no role. Or if premature rupture of membranes has happened, then there is no role of progesterone. If there is no history of preterm birth, but there are other risk factors. For example, if there is septate uterus or bicornuate uterus, or conception has happened due to ART, or if female is obese, then in all these cases there is no role of giving progesterone. Similarly, just now when I'll be talking about diagnosis of preterm labor, I will be talking about fetal fibronectin protein. So if fetal fibronectin protein is present, that means already the process of labor has started. The process of preterm labor has started. So if you are getting a positive fetal fibronectin protein, then there is no role of giving progesterone, right? And if female is undelivered after preterm labor, so suppose if there is a female who had an episode of preterm labor, she was having contractions and you gave her tocolytics, you gave her corticosteroid, and now her contractions have stopped and you are sending her home. In such a patient, I am not going to prescribe progesterone, right? So if preterm labor has happened, then there is no role of progesterone at all. Is that clear to all of you what I mean by fourth point which I have written there? That if there is a patient who has gone into preterm labor, you've given her corticosteroids, you've given her tocolytics, her contractions have stopped and you are sending her back home, then you are not going to prescribe her progesterone. In such females, there is no role of progesterone. Clear? Okay. Then the adverse effects of progesterone. So progesterone supplementation can come as a short note to all of you. So about progesterone, you should be knowing everything about progesterone. See, now please understand that use of progesterone has not been associated with any major adverse effects in mother and fetus. Minor side effects are seen which are related to the route of administration. For example, if you are giving intramuscular, then you may get injection site reactions. If you are giving vaginal progesterone, then the female may complain of vaginal irritation or discharge. There is no risk, no evidence of developing a risk of thromboembolism. So progesterone is not related to any risk of having venous thromboembolism. Now, risk of teratogenicity. Now, this is one thing which I want all of you to listen very carefully. So, there is some studies, a few studies did show that there is a possible increase in the risk of hypospadias in the male offspring if the mother was exposed to progesterone before 11 weeks of gestation, right? So a few studies did show that if a mother was taking progesterone before 11 weeks, their male offsprings, they possibly had a slight increase in risk of hypospadiasis. Now, although no further studies confirmed this, but by chance, even if it is confirmed, then the concern is not relevant in patients with prior preterm delivery, because just now I told you that whenever there is history of preterm birth, when do you start giving progesterone? You start giving progesterone from 16 weeks of gestation. And this risk was seen if progesterone was given in first trimester. So even if a female has history of preterm birth, just now I told you, you are going to give her progesterone starting between 16 to 20 weeks. Right? So even if these studies, they are completed and a few more studies, they show that yes, there is a risk of hypospadias, then in such females, I'm not worried because I'm giving them progesterone starting from 16 weeks and not before 11 weeks. Clear to all of you? Then there is no long-term risk of developmental effect. So there is no effect seen on mental health of the baby if their mothers were receiving progesterone. There is no effect seen on sexual or gender expressions. Then there is no effect on pubertal development. Nothing was seen, right? Then risk of cancer in offsprings. Yes, one trial showed that if a pregnant female was taking progesterone in first trimester, then the offspring had increased chances of cancer, and the chances which were increased were colorectal cancer, prostate cancer and pediatric brain cancer. Right? This is just one study which has shown this. Right? But whether this association is linked to current use of hydroxyprogesterone caprate to prevent preterm birth, in which treatment is initiated at 16 to 20 weeks, is not known, right? So again, the same thing. First trimester if you are giving progesterone, yes, one study showed that yes, there is a risk of prostate cancer or there is a risk of colorectal cancer or pediatric brain cancer. But again, for preterm birth, we are giving progesterone starting from 16 weeks and not in first trimester. That is why, again, this is irrelevant here, right? Now, as per the latest updates, the contraindications for giving progesterone are hormone sensitive cancer, liver disease, and uncontrolled hypertension in the mother. So these are the latest updates which say that progesterone should not be used in mothers who have hormone sensitive cancer, who have liver disease, or who have uncontrolled hypertension, right? So one important intervention which I told you which can prevent preterm birth is progesterone, and everything about progesterone I have told you, right? The second important intervention, is cervical cerclage. Now, before we talk about cervical cerclage, we have to talk about short cervix as a risk factor. Very, very important that how is short cervix a risk factor, and when are you going to screen a female? What category of females are you going to do screening for short cervix? All that is very important. So a very important topic I'm going to start, and that is short cervix, right? Now, short cervix. Now I'm going to read out a few important lines which are very theoretical, but then you may get a short note, and that is why I am compiling everything for you at one place, right? So cervical shortening is one of the first steps in the process leading to labor, and it can precede labor by several weeks. The cause is often unclear, but it has been attributed to occult uterine activity, uterine overdistension, congenital or acquired cervical insufficiency, infection, inflammation, and biological variation, right? So short cervix has been attributed to these things like occult uterine activity, where we don't know, we aren't able to measure the uterine activity, but uterine activity is happening. Congenital or acquired cervical insufficiency, infection, inflammation, and biological variation. Now, a short cervical length before 24 weeks is predictive of subsequent spontaneous preterm birth, especially if cervical shortening has occurred early in pregnancy, right? Number two, in those in whom there was history of early or repeated spontaneous preterm birth, right? So especially if you are getting short cervix early in pregnancy, then that is a predictive factor for preterm birth. Or if you are getting short cervix in females in whom already there is a history of preterm birth, right? Now, a very, very important thing to understand is that because effacement begins at the level of internal os and then it progresses caudally, right? So it is going to begin at the level of internal os, right? So it is going to begin at the level of internal os, and then it is going to proceed caudally. That is how cervical effacement is going to proceed. So obviously, if I am doing a per vaginal examination and I am doing a TVS, TVS is going to detect a shortening in cervical length much more quickly, much more earlier than a per vaginal examination, right? Because effacement is going to begin from the level of internal os and then it is going to proceed in the caudal direction, right? That is why whenever we are talking about shortening of cervix, we are talking about ultrasound measurement of cervix, right? And not about clinical assessment of cervix, right? So, why is it important to measure cervical length? Basically, it is important to measure cervical length because if there is no history of spontaneous preterm birth and in this pregnancy I am identifying that my patient has short cervix, then I know that if I give her vaginal progesterone, it will reduce the risk of spontaneous preterm birth, right? So that is why it is important to know whether the cervix is short or not, right? Or suppose if my patient has previous history of spontaneous preterm birth and she has short cervix in this pregnancy, then in such a case, not only I have to give her progesterone, then in that case, I also have to do cervical cerclage. Are you understanding this? So that is why measurement of cervical length is very important, because once I measure cervical length, I come to know how am I going to manage my patient. If the cervical length is less in this pregnancy and there is no previous history of preterm birth, then by and large I know that if I give her progesterone, I will be able to prevent her preterm labor. But if she has previous history of preterm birth and in this pregnancy her cervix is short, then only progesterone is not going to help in this case. Then in this case I will have to put a cervical cerclage, right? That is why it is very important to measure cervical length. Yes, during pregnancy. Clear to all of you? Now, how do you diagnose short cervix? So for the diagnosis of short cervix, the critical cutoff length which we take is 25 millimeters or less than that. So if the length of the cervix is 2.5 centimeters or less on TVS before 24 weeks, regardless of the population being evaluated, regardless of whether she has history of prior preterm birth or not, regardless of whether this is a single pregnancy or multiple pregnancy. Short cervix means if during pregnancy before 24 weeks, if a pregnant female is having cervix less than equal to 25 millimeters. Clear to all of you? Then we say that yes, this is a case of short cervix. Is that understood by all of you? Yes? Okay. Now, whom to screen? What are the category of females in whom you are going to do screening for cervical length? Now, FIGO has different guidelines for this, and American College ACOG has different guidelines. ACOG says that if there is a pregnant female who has previous history of preterm birth, then definitely in this pregnancy you have to screen her for cervical length. So what is ACOG saying? If a pregnant female has previous history of preterm birth, right, then in next pregnancy, in this pregnancy, I mean this time when she's pregnant, I have to screen her for short cervix. And I am going to do a TVS to screen her for short cervix. Now, if there is a pregnant female in whom there is no history of preterm birth, then in all such females, you should at least measure the length of the cervix once between 18 weeks to 22 weeks plus 6 days, right? Either with a transabdominal scan or transvaginal scan. Are you understanding what ACOG says? So practically ACOG is saying that in all pregnant females, we will have to measure their cervical length. If any pregnant female has previous history of preterm birth, then definitely by a transvaginal scan, you have to measure their cervical length, right? And in all the other females in whom there is no history of preterm birth, at least once you should measure their cervical length. You can do it transabdominally or you may do it transvaginally between 18 weeks to 22 weeks. Right? Now, on the other hand, FIGO. FIGO has no such thing that if there is history of preterm birth or no. FIGO simply says that all pregnant females in all pregnant females, you have to measure the cervical length once between 19 weeks to 24 weeks, and that has to be done by a TBS. Practically, unless and until they specifically ask you about ACOG guidelines and about FIGO guidelines, which you should be knowing if you are framing your answers as well. But practically, as a clinician, what are you going to remember? As a clinician, you are going to remember that in all pregnant females, you have to measure their cervical length once, which should be done between 18 weeks to 24 weeks, and ideally it should be done by a TBS. As a clinician, you are going to remember this much. But as a student, ACOG guidelines and FIGO guidelines, both you are going to remember, right? Now comes the detail thing, right? Now, the detail thing is how am I going to approach a pregnant female with short cervix, and how am I going to, manage them further. So, when and how should cervical length be measured? This is a algorithm which you have to remember, and this algorithm is going to solve so many questions and queries which you might be having. So suppose if there is a single pregnancy, this time singleton pregnancy, and there is no prior spontaneous preterm birth, or there is no twin gestation. So this could be a single, no history of prior preterm birth. In such females, I told you, what was ACOG saying? ACOG was saying that you do go for either transvaginal or you go for trans-abdominal scan, right? And you measure their cervical length at least once. FIGO was saying go for only transvaginal and measure their cervical length once. So now the general protocol which we follow is that yes, once we are going to measure their cervical length transvaginally, and we are going to do it approximately at 20 weeks, between 18 to 24 weeks, right? So you are going to do it approximately at 20 weeks, or you can say between 18 to 24 weeks once I'm going to measure their cervical length transvaginally. Now, if their cervical length is more than 25 millimeters, then you have to give them routine prenatal care, right? Then routine prenatal care has to be given, nothing else has to be done. Now, if cervical length in such females comes less than 25 millimeters, so it is less than 25 millimeters. Now, just now I told you, if there is no history of preterm birth and cervical length is short, then what is the management? Your management is vaginal progesterone, right? So I am going to give them vaginal progesterone. When am I going to give them? The moment I make the diagnosis. Till when am I going to give? I am going to give them till 36 weeks. Do I need to follow them up with serial cervical measurements? No. Now, once you've started progesterone, now you don't need to measure cervical length anymore, right? Okay. Now comes those category of females who have, this time they have a single pregnancy, and previously they do have history of preterm birth. Now, if previous preterm birth was happening at less than 28 weeks, right? Now, whether it is ACOG, whether it is FIGO, all of them were saying that in this category of females, you have to measure their cervical length, right? And but now comes that at what time am I going to measure the cervical length? If previous preterm birth had happened, at less than 28 weeks, then the right time to measure cervical length in them is 14 weeks of pregnancy, right? And if it happened at more than equal to 28 weeks, then 16 weeks of pregnancy. So between 14 to 16 weeks in these category of females, I am going to measure cervical length, right? Now, if cervical length is more than 3 centimeters, right? I'm not saying 2.5 just now. if cervical length is more than 3 centimeters. Now, in such category of females, it is not just one time that you have to measure cervical length. In this category of females, because they have previous history of preterm birth, they are at risk for having short cervix. So I will have to regularly screen them up for, the cervical length. So if the length of the cervix is more than 3 centimeters, then in that case, after every 2 weeks, I am going to repeat. Every 2 weeks, I am going to call them and I am going to repeat their cervical length, right? And I'm going to repeat it till 24 weeks. Till 24 weeks, I'm going to screen them. Now, if their cervical length is between 26 to 29, just now they have not reached 2.5 centimeters. It is between 26 to 29. Now, if it is between 26 to 29, then in that case, they are at slightly more risk of coming down to 2.5 centimeters. So instead of measuring their cervical length every 2 weeks, I am going to call them every week to get their cervical length measured. So are you understanding? Broadly, what I am telling you is that if there is previous history of spontaneous preterm birth, in this pregnancy, you start measuring their cervical length starting from 14 to 16 weeks. At 14 to 16 weeks, if the length of the cervix is more than 3 centimeters, then call them after every 2 weeks to measure their cervical length. Now, if their cervical length is between 26 millimeters to 29 millimeters, then call them every week. And if it is less than equal to 25 millimeters, then that is an indication for putting a cerclage as well as continuing progesterone supplementations. Clear to all of you? Any confusions over here? No. So now just quickly tell me, if a female comes to you with history of spontaneous preterm birth, what all is going in your mind? If a pregnant female is coming to you with history of spontaneous preterm birth, just now I told you that whenever there is history of spontaneous preterm birth, in such females from 16 weeks onwards, you put them on progesterone. Right, so I will put them on vaginal progesterone and simultaneously I am going to measure their cervical length. Right, and this measurement is not just going to be once. This will be a serial measurement of cervical length. Right, at any point of time, if their cervical length comes less than equal to 2.5 centimeters, then along with vaginal progesterone, I am going to do a cervical cerclage. Right? This is what I have told you just now. Is this all clear to all of you? Yes. How do you, screen and you manage a female with short cervix? I'm waiting for a thumbs up from all of you. Right? So I think there is some lag over here. And that is why I'm waiting for you all. I also have a class at 10 p.m. So I just hope we are able to finish all this in time. Okay. Right. So you people are understanding. So now coming to the second very important intervention, and that is cervical cerclage. Now again, a few important things about cervical cerclage. Now, cervical cerclage, they are those surgical procedures in which you are putting either a synthetic suture or you are putting a tape to reinforce the cervix, right? So you are putting cervical sutures or tapes so that the strength of the cervix is reinforced, right? So you are mechanically increasing the tensile strength of the cervix, and you are in a way preventing adverse perinatal events from happening, which could have happened if the length of the cervix would have been short or if the cervix would have dilated. Right? So what am I doing in cervical cerclage? In cervical cerclage, I am increasing the tensile strength of the cervix, and I am preventing the occurrence of adverse perinatal events associated with cervical insufficiency. And what are those adverse adverse perinatal effects associated with cervical insufficiency? Number one, prolapse of the fetal membranes into vagina. So I am preventing prolapse of fetal membranes into vagina. Number two, intra-amniotic infection. Number three, PPROM. Number four, preterm labor. And number five, fetal loss. So all these are events which I am trying to prevent by doing a cervical cerclage, right? Now, what are the indications for cervical cerclage? That's very, very important. Please remember that cervical insufficiency and cervical cerclage is a big topic which is related to abortions. So I will be taking it up separately. If I am going to teach you abortions also, then I'm going to take that up separately. Here I'm just telling you important points related to the indications for cervical cerclage. So, number one is if a pregnant female gives you history of 2 or more than 2 second trimester abortions, right? 2 or more than 2 second trimester abortions or extremely early preterm birth. So, extremely early preterm birth which was happening with no or minimal symptoms, right? So if preterm birth was happening at less than 28 weeks, or if you get history of 2 or more than 2 second trimester abortions, then that is an indication for doing cerclage, and this indication is called as history indicated cerclage. Right? Now the time for doing such a cerclage is between 12 to 14 weeks, and in such females we know that, just now I told you that if there is history of a preterm birth or if there is history of second trimester abortions here, then you have to start supplemental progesterone from 16 weeks, right? And if there is history of progesterone, either you are going to start hydroxyprogesterone caprate weekly or you are going to give vaginal progesterone daily, and this you are going to continue up till 36 weeks complete, right? Now, only one second trimester abortion or only one extremely preterm birth, right? So, if he was giving you history of 2 preterm births or 2 second trimester abortions, then I didn't do any ultrasound. In such females between 12 to 14 weeks, I put a cervical cerclage, and starting now I told you, you are going to do serial trans TVS for cervical length. So you are going to do serial cervical length measurements by doing transvaginal ultrasound, right? And if at any point of time cervical length is less than 25 millimeters, you are going to do a cervical cerclage, right? And simultaneously in all these females, you are going to give progesterone at starting from 16 weeks. Right? Now, because there is a short cervix, if there is short cervix, then in that case, the progesterone which you are going to give will be vaginal progesterone, right? This is indicated cerclage. Then comes physical examination based cerclage. So suppose if you have a pregnant female in whom cervical length was normal, in whom there was no history of preterm birth or no history of second trimester abortion, but you see that the cervix is dilated and it is effaced before 28 weeks of pregnancy, but there are no or weak or either there are no contractions or there are weak irregular contractions. All of you know that weak irregular contractions are not true labor pain. So this patient is just now not in preterm labor. she is having either weak irregular contractions or she is having no contractions but her cervix is dilated, right? Then also it is an indication for doing cerclage, and that is called as physical examination based cerclage. Preterm births, right? In that case, you don't even need to do a cervical length measurement. You simply have to put a cervical cerclage and you have to give them progesterone, right? Irrespective of the fact whether a cervix is short or not. Now, if you have a female who gives you history of 1 second trimester abortion or extremely preterm birth, then you have to go for serial measurements of the cervical length. And if cervical length comes out to be less than 25 millimeters, you are going to do a cerclage. In such females also, I have to start progesterone, right? So unless and until they have short cervix, I can give them hydroxyprogesterone caprolate. If I see that they have a short cervix, I will switch them over to vaginal progesterone, right? Then a physical examination based cerclage. Then comes the route. Cervical cerclage, it can be done by vaginal route or it can be done by abdominal route. Most commonly we go for vaginal route only if a female is giving you previous history of failed vaginal cerclage. Then we go for abdominal route, right? Now, in all cases where you are applying cerclage, you have to rule out true labor. Patient shouldn't be in true labor. Patient shouldn't be having infections like chorioamnionitis, and there shouldn't be any bleeding, for example, from placental abruption. So only after ruling out labor, infection and bleeding from placental abruption, you are going to apply cervical cerclage, right? Now, the contraindications for applying cervical cerclage. Contraindications are: if there is a fetal anomaly incompatible with life, then you do not apply cervical cerclage. If there are intrauterine infections, if patient is in active preterm labor, or if there has been preterm premature rupture of membranes, fetal demise, or active uterine bleeding. So just now I told you, you have to rule out labor, you have to rule out infections, and you have to rule out bleeding. Right? Apart from that, fetal, there shouldn't be any intrauterine death of the fetus. In all these cases, you are not going to put cervical cerclage. Clear to all of you? Now, what are the other interventions which can be used to decrease preterm birth? So, suppose if a female is giving you history of indicated preterm birth. So, suppose there was this female who in previous pregnancy had preeclampsia, and due to severe preeclampsia or eclampsia, her pregnancy was terminated at an early gestation, right? Now, in such females also, I told you that whenever there is indicated preterm birth, then also there are chances of recurrence. So, in such females also, there are chances of recurrence of preterm birth. Now, in such females, if it was, indicated, it was iatrogenic preterm birth. So, if there was history of iatrogenic preterm birth, it is not history of spontaneous preterm birth. There is history of iatrogenic preterm birth. So, suppose your patient is giving you history that I had preterm birth, but that preterm birth was because I was having preeclampsia or severe preeclampsia. Then I am not going to give her progesterone. Then I am going to give her aspirin now. Right? So, in next pregnancy, I am going to give her aspirin. This aspirin is going to decrease the chances of PIH, and simultaneously it is going to decrease the chances of preterm birth. So, if your patient has history of iatrogenic preterm birth or indicated preterm birth, then you have to treat the cause, right? Rather than saying that I am going to go for, progesterone, you are going to say that we will be treating the cause, right? Now, if there is history of cervical surgery, or if there is history of transcervical procedures like LEAP, so then again, in such cases, like you screen a normal pregnant female. I told you a normal pregnant female should be screened between 18 to 24 weeks. That's the normal clinical practice. What we do between 18 to 24 weeks, you are going to screen them by a single TBS. Just now in this algorithm we wrote. Right? If it is a single pregnancy, there is no prior spontaneous history of preterm birth, then in such cases, what you do? Then in such cases, you do a single ultrasound. Similarly, over here, if your patient has got history of a cervical surgery, right? Like LEAP or like cold knife conization. So you're going to take it as a normal pregnant female and you are going to just screen her once. You are just going to measure her cervical length once, and if her cervical length comes out to be short, then you are going to put her on progesterone supplementation, right? Now, if your patient has maternal chronic disease, then the intervention which you have to do is you have to optimization of the disease preconceptionally. So if she has diabetes, you have to optimize it before she conceives. Then hypertension, you have to advise her to optimize it before she conceives. Now, if there is multifetal pregnancy, multifetal pregnancy, as I told you, in itself is a risk factor. So in such, without any history of preterm birth, without any history of short cervix, in such cases the role of progesterone we don't know. It is not beneficial. If there is no history of preterm birth, if there is no history of there is no short cervix, in such females who have just multifetal pregnancy, progesterone is plus minus. The best way to decrease the chances of preterm birth is if you reduce the multifetal pregnancy to twin pregnancy, right? So that is the advice we can give to them. Now, in adolescent females and in older females who are becoming pregnant, it is better that you give them contraceptive advice so that next time they don't have such pregnancies, right? Then comes infections. So if a female is, as you know, infections is again a risk factor for preterm birth. So all pregnant females, you should screen them by a urine culture in first trimester so that you can detect asymptomatic bacteriuria. Right? All pregnant females, you should do a first trimester urine culture so that you can detect asymptomatic bacteriuria. And suppose a pregnant female is at high risk of having asymptomatic bacteriuria. Who are those females who have high risk? Females who are at high risk are those who have diabetes, those who have sickle cell trait, those who have renal disease, or those who have recurrent episodes of UTI. In such females, you should advise them screening with urine culture in every trimester, right? And the third important thing is that always in pregnancy, asymptomatic bacteriuria should be treated, right? So that asymptomatic bacteria doesn't lead to preterm birth, number one, in all pregnant females in first trimester, I'm going to do a urine culture. If a female has high risk for asymptomatic bacteriuria, you have to repeat urine culture in second and third trimester also. And number three, if you detect asymptomatic bacteriuria, then definitely you have to treat it. So these are all the interventions which you can do to prevent preterm labor from happening, right? Is that clear to all of you? So this is how this was the pathogenesis. This was the mechanism to, the interventions to prevent preterm labor and the risk factors in detail, right? Now comes another one more thing. Suppose if your pregnant female has history of vaginal bleeding, right? Now, in such females, there is no effective intervention which can prevent preterm birth, right? You may give them progesterone, but the role is really controversial. There is no role of abstinence in preventing preterm birth in these females, and bed rest is also not beneficial, right? So many times whenever a female comes to us with vaginal bleeding, we advise them abstinence, we advise them bed rest. But please remember, this bed rest and abstinence are not going to prevent preterm birth in them, right? Bed rest is said so commonly in government hospitals and in private settings, but actually bed rest has not much role. Bed rest का only role ये होता है कि it increases uteroplacental flow, and because it increases uteroplacental flow, it increases the birth weight of the fetus. But apart from that, bed rest doesn't have any role. As far as abstinence is concerned, although when any female comes to us with bleeding, we advise them abstinence, but still abstinence has a role in placenta previa. If you have a pregnant female with placenta previa, then yes, we tell them abstinence, and abstinence is advised to them. It has a role. But apart from that, any other bleeding which is happening, abstinence doesn't have a role in it, right? Now comes now, before I go further, I want all of you to tell me that whether you want me to continue with preterm labor and I teach you the tocolytics and corticosteroids today, or you want to take a break and you want to come back on Monday to read all this. Because already I can see it is 2 to 2.5 hours when we have been taking this up. Right? So I'm just waiting for your answers. I also have a session at 10 o'clock today for the NEET PG students. So, and this session at least, it is going to, just now I'm going to take more, 1 to 1.5, because I have to talk to you about GBS prophylaxis. I have to talk to you about corticosteroids and about tocolytics. So it is going to take time. So I think I am going to stop over here and we are going to complete this on probably on coming Monday. Is it okay with all of you? In the meanwhile, you can take down notes of all these things. Right? Thank you so much, all of you, for understanding. And I hope, you people are liking this series which I have started. I want honest feedback from all of you, because based on your feedback we are going to continue with these types of classes, and based on this I am, maybe we have an app soon for you people as well for OBGY residents. That is why it is my sincere request to all of you that once you watch this video, do not forget to share it with your friends and all those who are doing obs and gynae, and do not forget to leave a feedback for me. It is your feedback which is going to help me in knowing that whether you people are understanding or not. Right? So I'm going to wait for your feedbacks in the comment section, and let's meet again on Monday. And in the meanwhile, keep taking care of yourselves as well as your patients. And if you have any queries, you can write to me on my Instagram handle as well. That is Dr. Sakshi Arora, OBS and Gynae. Right? Okay, see you on Monday then, all of you. Take care, bacho.